All right. Hello, everyone. Welcome. Good afternoon. Thank you so much for joining us today. My name is Emily Moore. I'm the project manager for the Southeast Mental Health Technology Transfer Center, or the Southeast MHTTC. And we are so pleased to be partnering with our longtime collaborators today in the first of this three-part series, Measure for Measure, in which Georgia Mental Health Consumer Network and a few panelists will be going over the national standards for peer support certification. And without any further ado, just to make sure that we have all the time needed to go over this incredibly important information, I am going to go ahead and turn it over to our longtime friends at the Georgia Mental Health Consumer Network. So Chris and Heather, please take it away. Thanks so much.
All right. Thank you so much. We are once again thrilled to be here at the Southeast Mental Health Technology Transfer Center, learning along with you this time about the national standards for peer support certification. We are not going to cut too much into Wendy and Amy's time, and we're going to let them introduce themselves, even though they have so much to say about just what they've done. These two women have accomplished so much for peer support, and just it's amazing. I did want to say just a little about the standards, right? Like, what is a standard? The federal government has, these standards around everything, really. But for us, I think the most important thing that I want to keep in mind is they're going to change. There are a lot of standards buried in here, and over the years coming up, we're going to find out which ones work, which ones could be better. We're going to find out a lot about these standards, and the voice of the peer is going to be so important through that process, just like it's been important up to this point in the process, the development of them, because you're going to have the opportunity to hear from even more people. So I'm really excited about how we've been included and will continue to be. I'm Chris Johnson, the Director of Communications for the Georgia Mental Health Consumer Network, and this is my colleague, Heather.
Thank you, Chris. And thank you, Wendy and Amy, for joining us. As Chris said, my name is Heather James. I am the Chief Training and Development Officer for Georgia Mental Health Consumer Network. Thank you guys all for joining us today. If during this webinar, if anybody has any questions, please feel free to drop them in the chat, as well as you can post them in the Q&A. And Chris and myself will be monitoring them so that we can let Amy and Wendy know. Without further ado, I will let Wendy and Amy take it away.
Hello, everybody. We are so glad to be here with you today. And if you'll just give me a moment to convert this into the slideshow lens and view. Thank you. We will begin with our introductions. And so, Chris, thank you for acknowledging that Amy and I are knee-deep in promoting peer support, because it is just a passion that she and I share. And we will just do brief introductions around kind of what our roles are and in being with you today. So I am Wendy White-Tygreen, and I am with the Georgia Department of Behavioral Health and Developmental Disabilities, and have been for about 30 years now. And so had the privilege of being the scribe and chief plumber, is what I call it in state government, the chief plumber of building the money and the policy related to peer support when it was birthed in 1999. So we are celebrating in Georgia the 25th anniversary of Medicaid-approved peer support. And the launch of that, what it did fundamentally was to create a federal recognition of the value of individuals with lived expertise, lifting up others in their own recovery journeys. And becoming part of the whole team, which can support individuals with mental health or substance use concerns, whether or not they are young or young adults or adults or older adults. I'm not going to put any of us in any of those unique categories today, but just across the whole lifespan. And so it has created kind of a monumental shift in the way behavioral health services are delivered, changing really the whole conversation in behavioral health care settings for being more recovery focused. And so since that time, I've gone on to help 44 states, as well as several national agencies in the implementation of peer support. And one of those great agencies that I've been fortunate to work with is the agency with whom Amy works. And so with joy, I am turning it over to Amy to just introduce herself for a moment.
Thank you, Wendy. Good afternoon, everybody. Thank you, Chris, for that great introduction, and Heather. Definitely appreciate you guys having us here. I don't have as extensive of a background as Wendy Tygreen does in this space. However, I do have some lived experience in this space. So I am Amy Brinkley, Senior Recovery Support Systems Coordinator for the National Association of State Mental Health Program Directors. That's a long title. We simplify it by just saying NASHPD. Prior to working at NASHPD, however, I was the Peer Support Recovery Director for the state of Indiana. In Indiana, the organization is Division of Mental Health and Addiction, and I'm also a person with direct lived experience. By the grace of God, I have been in self-identified recovery from both mental health and substance use challenges for 15 years. I became a certified peer for the state of Indiana in around 2012. And then went on to work at the state, and now I'm working, I get to work with other state recovery leaders around the advancement and infrastructure building for peer recovery support services. So it's definitely an exciting time to be in the space, and I'm definitely happy to be here. Back to you, Wendy.
So, yeah, you can tell we brought the big guns today. Amy is such a amazing national leader and just has such a great way of amplifying lived expertise to kind of all the state and federal partners with whom all of us are engaged to promote peer support. So, so together, I think we'll be able to kind of lead you through a kind of a hearty presentation here today on the content and the data that we are sharing. So we together are going to talk to you about the national model standards. And Chris introduced the concept at the very beginning of our dialogue, but we are going to help you have a much richer understanding of those without dragging you, we hope, too deep into the weeds, because many of you have roles where you will need to understand these and in a lot of depth, and some of you have roles where you just need to know a little bit about them, be able to kind of be shapers and influencers of the policy dialogue in the future. So today we're going to hit on the origin of the national model standards, just where and why did they start kind of percolating at this point in time? The premise for those standards, so once a decision was made to embark upon a journey towards creating national model standards, like what were some of the fundamental premises for that? And then a broad orientation to content. And then we're going to look at a tool for self-assessment. So with that, I'm going to turn it to my colleague, Amy, who was one of the extraordinary leaders nationally who was in place when some of this work began emerging, and let her take the next few slides with you.
Thank you, Wendy. So where things kind of kicked off here is in 2022, the Biden Unity Agenda released a call out for a national peer certification. And historically speaking, it was the first time that anything like this had happened that included peers. And so it was a pretty exciting time, as you guys probably recall. Folks, I mean, we were all super excited about it. So it was a national conversation there for that first year. And what we saw as the conversation continued to evolve is a call out from the newly appointed SAMHSA Office of Recovery to address the Biden Unity Agenda's call for a national peer certification. Equally important to note here, however, is that we know, historically speaking, that other organizations have attempted to create a national peer certification in the past that were not very successful in terms of getting buy-in from all of the states and territories. And so what we know is that thanks to a Peer Recovery Center of Excellence and this great comparative analysis report they did last year, all states except for one, I believe it is, has a peer certification in place already. So the development of a national peer certification could be, well, at the time we were having these discussions, would have been duplicative in terms of what the states already have in place. And then also unnecessary because states already have their peer certification programs in place. So SAMHSA sort of pivoted here. And you can go to the next slide, Wendy. SAMHSA sort of pivoted here and started focusing on a SAMHSA peer model standards instead. And so, Wendy, do you have anything that you want to add related to this particular slide? If you want, I can go ahead and cover it.
You can go ahead.
Okay, so there were a lot of assumptions made about SAMHSA pivoting in this way and developing the model standards, and that is strengthening system capacity. So they, especially related to the crisis infrastructure, we know that there's a call out on the inclusion of increasing access to peer support within the crisis services infrastructure that's being developed right now. And then mitigating the behavioral health workforce shortage, which my entire first year at NASPID in 2022, I sat with all of the state mental health commissioners for that first year. And the top issue facing every single state in the nation was behavioral health workforce shortages. And then what this could also do is expand supply of workforce. And I would say primarily what we believe the premise was in developing the model peer standards was the idea of developing reciprocity between states. So if someone leaves the state of Georgia, for example, and maybe moves to Indiana, ideally their certification would be just as valid in Indiana or any other state as it is in Georgia, without having to, take the test and go through the training again. So those were kind of a premise and assumptions made on why SAMHSA's Office of Recovery championed the SAMHSA peer model standards. However, we've kind of leaned into the idea that it's mostly around reciprocity and in response to the Biden Unity Agenda. Next slide. So the model standards, I kind of covered this already. So the model standards are not a mandate. I'll start here. I'll start at the bottom. So the model standards are, first of all, not a mandate. SAMHSA cannot mandate that any state adhere to their peer model standards. And so that was communicated clearly throughout the entire development of the model standards. Myself, and I've seen several people on the call, were actually part of the development of the model standards. So they were very inclusive in terms of collaborating with federal, state, tribal and local stakeholders in the development of the model standards. We had several states, including myself, that were part of this process as well. And it was overly communicated to the states and the participants that this would not be a mandate. And there is a focus within the SAMHSA model standards on substance use, mental health, and family peer certifications. So it's broad. Next slide, please. And you'll see that throughout the standards. So this is going to be the summary version If you, I don't have the link handy right now, but if, Wendy, if you have it, share it. If not, I'll share it in a moment. But if you look at the model standards in depth, they are so much broader than what we're going to cover here today. So this is the summary version. So go, yeah. So the first standard is around authenticity. And the SAMHSA recommendation is that prospective peers should be able to describe their lived experience, which I know from seeing several states' peer certification trainings that usually there's a component of sharing your story with your classmates that happens at the training level. So this kind of emphasizes and undergirds that principle. The next standard was around diversity, equity, and inclusion. And the SAMHSA model standard stated that ensure access to prospective peers who may also have disabilities or other barriers. And they also included in great detail strategies on how states can increase access to peer certification. And an example I'll give, and this is sort of throwing myself under the bus, but when I worked in the state of Indiana, we never did have our peer certification training offered in any other language. And we should and could. So that's something that at least the state that I live in, we're taking away from this. The third standard was around ethics. And that model standard stated that states' certifications should have peer ethics committees made up of peers to review and assess reported ethical violations. I know from being in the state government as well as working with other states who oversee peer certifications, this is a conversation that we have a lot because, things happen within the peer space and it gets reported up to the state. And so then it just brings up this whole debate and dialogue about what is the state's role in response to those potential ethics violations. And then what's the peer certification board's role, which we didn't have one in Indiana. So it was the peer certification vendor. What was their role? What was the state's role? We had to pull in legal and it gets tricky. And so we see this happening in states across the country and every state has their own process. So ideally, ethics, this would help standardize the ethics across state certifications. The fourth standard was around examinations. And so there was a lot of detail in there that's not represented here. So the summary here is that as it relates to the content of the exam, the content should relate directly to and be appropriately based on the peer's role, whether it's mental health, substance use, or a family member. And the exam should only reflect information that was explicitly covered during the training. As it relates to the development and revision of exams, the recommendation is that the development and revision is led by certified peer workers to promote fidelity and reliability and involves collaboration with other state certification entities to encourage alignment and reciprocity, structure, format, and accommodation of the exams. The fifth standard was around cost and fees. The recommendation said that state certification entities should seek for pathways to subsidize and pay for all peer certification and recertification costs. Standard 6 was specific to training and the quantity of hours for training. Nationally, we know that the training hours they vary significantly on both ends of the spectrum. So SAMHSA's recommendation was that training requirements range from 40 to 60 hours for mental health, substance use, and or family peer certifications. And then specific to the content facilitation, it should incorporate the accommodations outlined in the model standard number 8 around diversity, equity, inclusion, and accessibility. Next slide, please. And then number 7, around supervised work experience, same thing here. Nationally, we see this looks extremely different on both ends of the spectrum across the state, or I'm sorry, across the country as it relates to each state. And then the recommendation here is that the maximum number of supervised hours required for certification should be 120 hours. And for states that require supervision hours, all prospective peers should be able to access a list of eligible sites to get supervision hours. Specific to standard number 8 around background checks, the recommendation is that there should be no background check required at the certification level. Interestingly enough, I'm sitting in a hotel room right now in Ohio about to present on best practices for hiring peers with felony backgrounds. And it just so happens that Ohio is a state that actually has a background check requirement at the certification level. So what this standard does, what the recommendation here for this standard does is it removes that barrier for peers related to their background and puts the onus back on the employer. So there could be we could be unintentionally screening out peers from getting certified who could go work in a peer run organization that maybe has looser background requirements to be hired at the certification level. So that was a good standard. Number 9, around formal education. No formal education should be required for certification. And there's a lot of content in the full standards that you can look at in terms of why and what other competencies can be met that support this recommendation. And then around recovery, no length of absence or recovery time requirements, as we all know with the expansion of harm reduction and the infrastructure around harm reduction. I would venture to say 8, 9, and 10, may seem pretty loose for some states. But it's not saying that these 3 areas, there shouldn't be any standards. What it's saying is that not at the certification level. These 3 areas of standards should be determinations made by an employer, not a peer certification requirement. And then around number 11, peer supervision, state certification entities should require that prospective certified peer supervisors have direct experience as a peer worker and relevant lived experience and a deep understanding of the skills, values, and principles of the peer role. And there's a whole section on the peer supervision standard as well. So this is just the summary version of the 11 standards that were recommended in SAMHSA's model standards. And ideally, and I'll say this last thing and I'll pass it back to Wendy, but ideally what we believe SAMHSA's goal with these standards are that this would be a floor for states to find common ground and build some reciprocity. So what we're seeing happening in several regions now is that SAMHSA regional representatives are pulling together the states in their region, and there's not necessarily compact agreements, but kind of compact agreements being made around these standards that build reciprocity, at least for their region. So I think the long-term goal here, and I can't speak for SAMHSA, but I do believe that the long-term goal here around the reciprocity is that we would expand the peer workforce and expand access to reciprocity between all the states. So Wendy, anything I missed or anything you want to correct?
No, I do want to add in for standard 11, this became quite an interesting dialogue between 2 federal agencies. So peer supervision, we really, I think folks who believe so deeply in the skill set of certified peer specialists really believe in this standard. And yet there was kind of a barrier in that there was a federal memo from Federal Centers for Medicare and Medicaid Services in 2007, which said it used the language that a supervisor needed to be a mental health professional. And they used it in lowercase letters, but in many states, a mental health professional is defined in the law or in regulation. And so mental health professional, for instance, in Georgia, had been defined as somebody who has a independent practice license. So like an LCSW, licensed clinical social worker, or a licensed professional counselor, a licensed psychologist. Those were folks who were identified as mental health professionals in Georgia statute. And so with that, it became quite a challenge for states and they had to set up supervision models with supervisors being folks who had that level of training, supervision, and independent licensing that then generally subsequently comes from the master's degree supervision and licensing testing process. So, so some states were able to get some flexibilities in if they didn't have a definition of mental health professional that was used in that memo. We know that 2008 began the first wave of certified peer specialists in the from the addiction lived expertise pool of professionals, and we kicked off that in Georgia as well. But we there was kind of a bit of a variance then in this real value-based belief, which you see here on the screen as number 11, versus what states were able to either convince the federal Medicaid agency where peers could be approved as supervisors, or sometimes it was locally, like I was indicating, in a local statute or a local regulation where mental health professional was already defined. And so folks were using their most the tightest of lens on that process. But as of June 5th of this year, June 5th, 2024, the Federal Medicaid Agency released some new questions and answers on peer support. And that is posted now on a federal website. And Amy and I had the benefit of being with peer leaders from all over the country in Kansas City on the day after it was released to have a mini celebration because CMS has now stated that they are more than accepting and willing to allow certified peer specialists to be supervised by other experienced certified peer specialists. And so states all over the country are considering then modifying what they may have put as language in their Medicaid state plans so that then new practice models can roll out. Now, I'm taking, you can tell, like a little bit of a sidebar here, but I think it's very important. If you don't understand how the pathway to changing something with Medicaid, sometimes it's a little rigorous and it's a little time laden. But I just want you to understand that most state directors who do recovery work are spending some time currently reconsidering peer supervision and how they would better define peer supervision such that certified peer specialists can have that ability to do that supervisory work. They can have that career ladder opportunity to move into a supervisory role. And then they're working then to define what does that direct experience look like? Like how many years would be the right amount? You know, what type of service and work have you been doing that would, you know, really enable you to be prepared to be a supervisor of the work? And then what has to happen is a behavioral health authority in a state like the one in which I work would have to go to the Medicaid agency, and they would have to make a formal request of the state Medicaid agency. If that language is written all the way into a Medicaid state plan, an official plan at the federal level, then you have to go through a whole board notice process in your state, and then you have to submit the new game plan and the new language to the federal government, the federal Medicaid agency, for them to accept or deny or to tweak the language that you've submitted together. So states are considering this, but it probably won't be anything that feels like an immediate shift in the workforce for a few months still to go. But there's a small group in Georgia who's at least, we've mentioned this item and we have it on a working to-do list of things that we're wanting to consider for this. But other states are in that very same process right now. We do know a couple of states who've already worked this through and who are kind of like the test scenarios for CMS to see what would get approved, and they've managed to receive kind of levels of approval for that. So we're very excited about that clarity from the federal government. So I wanted to hover here for just a second, because for many of you, this may feel like idealistic, because it seems like SAMHSA, another federal agency, is saying this is a standard, but it felt like CMS had this ceiling on top of it. But this gives us the chance now with this other sister federal agency to say, no, it's okay. You can do this. It gives us a chance to actually really richly implement Standard 11 ultimately around the country. So I wanted to pause there a second on that one, Amy. Any additional reflections from you now on what I was just sharing?
No, I put the link in the chat to that CMS guidance, though I threw it in there twice just to let folks know.
Thank you. And it dawned on me when I offered to put the other link in that I'm sharing the slides, so I couldn't do it without dropping out. So we'll get that to you. It's cited in the slide presentation, and we are happy to make the deck accessible through the MHTTC for you guys. Okay, so Amy gave a very high level of the standards, and we can look at some more detail at the end of our time together, depending on how much time we have. But we really wanted to come back to some of the big key ideas that Amy began introducing. So she started to say, the feds were thinking about reciprocity and what reciprocity might look like in the future. But states, also are like doing this assessment process of, do our curriculum actually meet the model standards? And, when we take a hard look at them, do they really meet this expectation? And then if not, how do we all set ourselves up with a quality improvement mindset so that we're really working together to figure out how to move all of the curriculum across the country to a level of saying, yes, we all meet these model standards. And back to Chris's point, well, and then over time, are some adjusted slightly downward, are some adjusted upward? Are there new ones added? So I think anytime standards are published, Chris was right to acknowledge that then they become your floor and they become your premise upon which you then start to think about, what do we need to do in the future? So I want to just point out the bullet that's on the page. Within the model standards, the document actually says this statement right here. Oh, I'm so sorry, because it just bumped me to a different slide. The purpose of the standards were to promote quality, encourage alignment, and reciprocity across often disparate state peer support certifications. So if you start to kind of unpack that statement a little bit, in some ways it gives us the chance to think about like considering this if you have multiple certifications in the state. So some states have several vendors who do this work. Some states have like one vendor per peer certification type. So a state could have an adult mental health certification, an adult substance use lived experience certification, a youth certification, an aging certification, a forensic certification. And so really you could look at this within a state to think about how all of your standards are similar. And again, like my lived experience is largely in Georgia, and the partners at the table, the Georgia Mental Health Consumer Network, are participating right now in a very rigorous and robust process where each of them is assessing themselves against the model standards. And what we hope to do next then is to bring all of those self-assessments together to figure out how everybody's doing, right? And we've asked for candor. We have some meetings where we're talking about this stuff with a lot of honesty, where all of our organizations are in one room at the same time, and we're saying, how did you self-score yourself on this, right? Like, how are you writing that up? We do it this way, we do it this way. What should we put together down on these different forms? And the hope is for the state of Georgia that then where we see gaps, and there we acknowledge there are some gaps, but where we see them, then we can collectively go consider resources or strategies or plans to make that improvement so that we're all improving together, and all ships are rising. So I think that SAMHSA was really pretty clear. Interestingly, in the back of the document, in the back of the model standards, there is a great exhibit, Exhibit B, which I have copied here in its entirety for you, where SAMHSA and the team have just laid out for readers guiding questions for revising peer certifications. So what they're really saying is, now that you've finished this process and you've gone through your national standards, now tell us what you would like to have done or understood about what to do next. So I think these questions are extraordinarily helpful for all of you to understand how these certifying entities, these training entities, can be examining these types of questions for future improvement. So, like, for instance, asking yourself, so say you go through the model standards and you use a tool and you do some self-assessment, at the end of the process, asking yourself, does our certification ensure that prospective certified peers have lived or living experience that aligns with the population they serve? Well, I think if you've gone through the tool, you can clearly answer that question. But if the answer to that is mostly, then you want to do some work and some effort to get it to 100%. I can definitely say we meet that one. Big, bright green check mark on this one. So you have to kind of then see that even SAMHSA and the publication of the standards is saying, ask yourselves, does our training curriculum really meet what the model standards are? And let us ask ourselves some questions like these that you see on the screen right now. So again, I think a second great item is like number 8. Do we have a code of ethics that was written by peer workers? Some states, most states do. That there was a team of folks of lived experience professionals who sat at the table and talked with state authorities about let's establish these ethics. But in some cases, that folks don't remember that, or they're even real clear that those ethics were birthed outside of the lived experience lens or voice. And so folks don't feel comfortable with that. And okay, well, we were able to say we have ethics, but should we revisit them? And so I think you can see the types of questions that are just really uniquely necessary for you to ultimately understand the that your certification and training processes ultimately meet the national model standards. Amy, any comments on that before I go?
No, you're very thorough, Wendy.
So I'm going to begin showing you a state self-assessment tool that I helped work on creating with a state that I was working with through SAMHSA to NASHFID to a state grant. And so there is a tool that is available to states that just on page 1, as you see here, just really lays out the context for what this thing is. What are the national model standards? And again, I think honing in for 1 second on items 1 through 8 here at the bottom. And here's kind of what should be expected by going through this work. So the first thing, and you've heard Amy and I mention it, number 1 towards the bottom of the page, is that ultimately, like, reciprocity and partnership between state entities might be fostered. Now, that may take us a few years, y'all. You heard Amy mention some states are already kind of jumping in on the reciprocity factor. But if you really think about doing a good hard look at your certification program against the standards, and you do that in partnership with the other folks locally, then you can determine for like your state or your territory that yes, we meet these together, and that a certified peer specialist that emerges out of one identified and recognized training and curriculum entity is the same as, you know, a peer specialist that emerges from another sister agency, and doing that work collaboratively. And then, right, like then in out years, folks could say, well, we met with South Carolina, which is Georgia's next door neighbor. Do our certification standards kind of, did theirs kind of meet the same standard of quality that ours did? Did they do a self-assessment tool? Do we feel confident about that? If so, maybe then in communities, you know, like Augusta and North Augusta, which are really one town on the Georgia and South Carolina border, maybe ultimately like peer specialists who are certified in South Carolina could work in our community behavioral health center if it's in Augusta. But that's, again, like some stages out in the future. And then over time, what can be done regionally and nationally then for this? So it's not a kind of one and done, like, let's review ourselves against the standards, check. It's really a process that should be moving the whole country forward in considering how to think about reciprocity and identification across state lines of some of these credentials. And let me just say, I used as an example last Friday in a group here in Georgia. this has not been totally worked out for licensed clinical social workers or licensed professional counselors. So there are state compact agreements that are emerging to recognize across lines those types of practitioners, but they are not smooth. Those processes are not smooth at all. And some of the variations between and among states are significant. So it may take us a little bit as a country to do this. But again, you have to launch from somewhere, which is what SAMHSA has done for us by creating national model standards. The second one is promote quality of peer services being delivered across the country. So if one area, for instance, might have a set of like certification content that has really been subpar, or it's not been fully, it's just a couple hours, or just doesn't address major key themes about recovery, then it threatens the quality of what people understand to be peer support if those peer support workers are going to work in systems and not doing a great job at delivering the service. And we want everybody who delivers peer support to be doing it out of the base kind of construct for the service that makes it so powerful, which is that the lived experience is what fuels others' recovery journeys. The authenticity of peers through promotion of and emphasis on lived and living experience. There are some other certifications that have started to use like the lived experience, phrase with it, but we really kind of want peer support certification for there to be kind of a unique and high quality standard for that understanding of service delivery. To be sure that state certification entities are developing and revising certification work content in the curriculum in order to continue to lift the field towards higher quality. Number 5, to cultivate the peer workforce by, again, like elevating the profession, bringing national attention to it, saying peer specialists are just the bomb. And that stands in Oregon, it stands in New Mexico, and that stands in Georgia, and being clear on that. Reinforcing the scope of the peer role through certification criteria, strengthening diversity and equity, inclusion, and accessibility, and expanding career pathways for certified peer workers and peer supervisors. So the tool kind of lays this out, but that's kind of a fundamental part of the standards that we wanted to highlight. And then here we go. So this tool that I'm sharing right here, page 1 of of the actual product work, is really designed then to take every single standard. If you'll see the very bottom row at the bottom of the screen. So model standard 1, authenticity and lived experience. What you see in this tool is the macro standard, and Amy went over those in a few slides back. At the high level, really, we want everybody to be super sure that everybody who's making an application to become a peer specialist is considering self-attestation. They are talking about willingness to share their experience with a mental health or substance use condition or other unique conditions and experiences which make them unique. So like a forensic peer specialist having some experience with jails, prisons, community supervision, or personally, and that now they're in recovery and can share and lift up those folks, not just from a baseline perspective, but also kind of this add-on lived experience in kind of the forensic realm. So the tool then takes the macro standard in column 1, authenticity and lived experience. Then everything that the tool says the model standards, when you go online and look at them, it's all in narrative. It's lots of paragraphs. But this then takes the content from each of those paragraphs and it narrows it down into a direct citation. So you can say, oh, the question for us is the state certification entities include a self-attestation requirement that promotes the following. So does it? Yes or no? And sometimes the SAMHSA guideline goes into a little bit more narrative detail, and those factors are all laid out in column 3. So consider these specialty areas like forensic or older adults or veterans, right? And then column 3, 4, and 5 are largely all unpopulated because that's where the entities, the training and certification entities, have to write their self-assessment status. So if, for instance, the application that a state training body has, the application says, tell us about your lived experience. And, there's certain aspects that folks are supposed to tell about when they make an application, then that would be the evidence. So you'd name the tool in column 4 and say, yes, we've done it. We're awesome. But if, for example, you don't have a good question on that, or you don't have a signed attestation, that column would be blank, and you would identify over in the next column the gap. Wow, on our application, it says certified peer specialist, but we didn't define precisely what that lived experience means, and we didn't ask precisely how that should be filled out. We didn't say we want you to tell us a little bit about your story right here. And maybe you want to improve that. So that becomes an identified gap. And then if you know how to fix it, write an improvement strategy, you just write that into the final column. And then what we are learning as states do this, and this is I've had the chance to work with at least 3 states on the tool, is then what we're seeing is trends. So there are some areas where there may be a significant deficit, and nobody's really thought about it, but we really, really should. So could we provide the testing in Braille? So that is a great accessibility question. And unfortunately, not a lot of certifying bodies have had all their tests translated over into Braille, or their booklets and workbooks shifted into Braille. And so, well, if that's the case, then what might we do together as training and certifying entities to try to raise the bar on that, so we can put that we have that, and that would move over into evidence of completion and accomplishment instead of it being an improvement strategy in the future. So that just gives you a sense then of how the tool can be used. And then I'm going to go ahead and just talk a little bit about what might be ahead. And you've heard Amy and I both talk about this, but we're going to just talk about this briefly here, and then really open the floor for addressing your questions and your dialogue, things that have been coming in the chat and the Q&A for a portion of our time. But what's ahead? So I want to just underscore some themes that you've been hearing. So quality improvement, which is just right, in the most fundamental of ways of defining, quality improvement is examining something, and then like taking an item and saying, we're going to examine this and we're going to make some changes maybe. So you plan for those changes, you implement them, and you kind of roll out a change or two, and then you assess it. And then once you assess it and go, oh, this didn't work, this did work, then you act on it. You kind of come back and do some fixing. So quality improvement is really just the process of just taking a moment and saying, do we need to make some small tweaks to make this better? And so we really hope that everything that we've talked about here that you're receiving from a quality improvement lens. Right now, again, as Amy indicated, it is not a mandate. So nobody is asking for assessments, self-assessments. Nobody's asking you to declare you meet this totally. And we are encouraging folks to be as candid as possible when doing self-assessment so that you have the opportunities to improve, right? Like if you put big green check marks by everything, then you're like, I am perfect and there's no need for any refinement. I think all of us can say we all have an opportunity for refinement. And so quality improvement then becomes crucial. Standardization. Again, what's funny in Georgia is in 2018, we rolled out this document. Our goal was to say a certified peer specialist for mental health in the adult side is the same as a certified peer specialist for adult on the SUD side, as for the youth side, as for the parent side. We really wanted to be able to say we had standardization. So we actually did a matrix in Georgia to lay out how all those things were similar and how when we certified a peer specialist in Georgia, but those things were the same. That means a lot because, I mean, when you're talking about like integrated healthcare and you're talking about does an emergency department hire a CPS? You don't want the emergency department to experience that your peer specialists that are coming from your parent certification are radically different about using their lived experience as a tool for helping others in recovery as those who are adults who had mental health lived expertise themselves. So you need your branding, right, for certified peer specialists to have some standardization. With specialization, like let's recognize we're not talking about throwing specialization out, not by any means, but a good standard foundation that is shared is crucial. And then, of course, we think in years to come, that reciprocity is going to be part of this conversation. It was some of the original goal just by having a national certification. But of course, once I think the federal government really kind of took a good scan of how many certifying training entities there were around the country, that lost its feasibility. And so reciprocity and being able to like have portability, that's another big word, like being able to move across state lines. If your family relocated from North Dakota to North Carolina, like, could you actually go to work and practice? Like, how would that work? So we don't feel like those things are, able to just be bottled and distributed and it all come out okay. It's going to take our collective work together. It's going to take some time. And we look forward to a future, though, where if you're a certified peer specialist, that really means something. It means something to the whole healthcare network. It means something to everybody receiving services that they want to ask for a peer specialist in a standard way. And they understand what working with a peer specialist will bring them, very much like they understand what working with a nurse will bring them. And so those are kind of the crucial takeaway aspects for what we hope and anticipate is around the corner in our future. I provided like the primary references for the standards. It's a document you can actually download from online and see all of this depth of content that Amy and I have shortened radically for this conversation here today. And we are prepared to address questions.
Thank you so much, Wendy and Amy. We did have a few questions in the chat. One of them did ask if the presentation was going to be shared, and I know you did address that. You did say that you would provide a copy of the slides to be shared through MHTTC. Sorry, I was copying and pasting them. I had a question from Frederick Sherman asked, will there be a guiding principle that impacts private practice for those with background challenges?
So there is no, again, mandate on that right now. Like reciprocity, folks, is reciprocity in the future, right? Like nobody's got really good reciprocity right now. My friend and colleague Jean Olszewski made a comment that she was able to have reciprocity, and we examined some of that here in Georgia because we had a shared curriculum that actually was bought by multiple states. So when we had that kind of thing, we knew it was an identical standard. We could shift and modify some of this work and recognize some reciprocity with states that had the same curriculum. Now, until you kind of go through that exercise and know that, then you can't do that. It's going to be the same, though, for these background check policies. And that gets a lot more unique because state Medicaid agencies have their own unique rules, and their health facility regulation divisions, like that do rules and regulations for certain services, may also have different laws and regulations across different states. So I think that would be an awesome thing. I just think that's going to take a lot more time. In order to do kind of that background check work, your state has to have a good policy on this. We're blessed that Georgia went through the sweat equity with a lot of lawyers to get us ready to do that. And there's a great product that NASHPD has produced on this, recognizing kind of some best steps to even just be sure it's in your state. But crossing interstate lines is going to be a lot more complicated. And but Amy and I will certainly be mindful that there's desire and hope on that. But I think the best place to start would be with the national publication that the National Association of State Mental Health Program Directors publish, and Amy helped write that.
Thank you. Another question was, does Prospect 1 interfere with the autonomy of various states to qualify beyond biases per territory? And that also came from Frederick Sherman.
Can you read that one more time or point me where it is, Heather, just so I can, it was so long, I just need to do deeper processing.
Yeah, it would, I'll read it again. Say, it came from the chat around 1:46 p.m. It says, does Prospect 1 interfere with the autonomy of various states to qualify beyond biases per territory?
Right. So I might have to lean into some assumptions here. So two things, the autonomy of states. I think that's why SAMHSA backed away from and the White House backed away from a single national certification because of unique cultural preferences and dynamics. And when I think about territory, I mean, you could just think about that generalist, like a geographic area, or I think about our territories, the U.S. territories, where there are a lot of different cultural practices and diversity and equity nuances that I think could also be in play there. I think ultimately the fundamentals of the standards are really about honoring lived experience, which if you are certified in one area, I think based on everything I've known about peer curricula, it really is about honoring them, the person who you are working with, and their very unique lived experience, and recognizing the intersections while honoring the differences. And so, I there could be a couple of different ways to read that. So I just want to, if Frederick just wants to chat in some more information, that may have gotten the question and it may not have. Amy, I don't know, do you have a different take on?
Not without seeing the question that they were referencing. I know it was in the slide around recommended next steps from SAMHSA, but I was trying to find it, so I don't have anything. I mean, I think you responded based off of the lack of awareness on my part of exactly what question or what bullet they were looking at.
Yeah.
Yeah, Frederick, if you have more information that you'd like to share, if you could drop that in the chat, that would be very helpful. The next question that we received was dealing with the CPRP certification, and they asked, is the CPRP certification required for peer support directors in Georgia?
Right now, it is required for program directors. So if you're overseeing like a whole program, like a peer support program that like operates 25 hours a week, or a certified, a psychosocial rehabilitation program that operates, up to 25 hours a week. Those types of big program areas, we do require a CPRP, but that's not a federal standard. That's a Georgia standard. And it was what was built in the absence of this new national guidance from federal Medicaid from June 5th, which changed the expectations of supervision. So we were really looking to kind of create a pathway for peer specialists to be able to be supervisors, kind of staying in the lane of ahead of a mental health professional, giving them a little bit extra boost. But we expect for Georgia, and I know not everybody on here is from Georgia, but that would be a reconsideration in the future based on the new supervision guidance from federal Medicaid.
Yeah. I have a question from Wendell Phil says, what is the peer specialist booklet we can look up? If you could expand on that one for us, Wendell. I don't know if are you talking about regarding the standards or like a specific training? That would be helpful. Claire Bonnell asks, how do we help support education for an agency's understanding of peer support in the peer workforce population on a national level?
Amy, you want to take that one first?
Yeah, I can take a stab at it. It's not really 100% clear to me the way that question is written, but my first thought that came to mind is that SAMHSA has so many resources out there, as does the Peer Recovery Center of Excellence on the peer role. I know there's a SAMHSA crisis peer advisory document out that talks significantly about peer role drift at the individual and organizational level. And I know the Peer Recovery, and I'll find the link and drop it in the chat when I'm done talking, but the Peer Recovery Center of Excellence has tons of recently published materials that could help someone develop a PowerPoint or a slide deck on educating employers. And I'll find the link and stick it in the chat.
And if the booklet mentioned was the SAMHSA guidance, for the model standards. So again, like Amy and I, we culled out those big headers, right, to put on the slides. And then we showed you like a tool that kind of culls out all of that and organizes it in a table. But if anybody's wanting to read the narrative big version of this, I just put that link in the chat. And it's from the SAMHSA store is what they call it. But it's available at the link I just provided.
Yeah,
I
it
want to
looks
add
like, oh, sorry, it looked like Wendell said yes, the standard, the slide before the end. That's what he was referencing.
I just put the link to the Peer Recovery Center of Excellence in the chat. And I also wanted to note one other thing that SAMHSA has been working this last year with C4 Innovations to stand up a new technical assistance center. And that's SPARK, which stands for SAMHSA's Program to Advance Recovery Knowledge. And not only is there free TA there, but there's also a resource library that is being developed. So if you don't find what you need on the Peer Recovery Center of Excellence website that I just put in the chat, you can also reach out to Spark and get a free TA and access all of the resources. Because I know SAMHSA has been doing a lot of things the last 2 years in terms of technical expert panels and webinars and pulling people together in face-to-face meetings, addressing different populations. Like there's just a lot of moving parts. And so Spark is a great way to dial in on what your actual request is and getting support for that.
Thank you. We have, that was answered. Question from Jean Olszewski asks, how will or if the national peer standard, the national peer model standards and standards occupational classification interrelate or impact peer services?
So the standards classification work, and I encourage all of you to keep an eye on it. I encourage all of you to keep an eye on it. So great news, about a year ago, maybe a year and a half, the Department of Labor, in its professional classifications, recognized peer support specialist. And that was great news, y'all. Because it's not been recognized before. And like we've been recognized by SAMHSA and recognized by HRSA and recognized from CMS and ACL. Like there's so many federal agencies, the VA, who've recognized peer support, but the Department of Labor had not recognized it. They embarked on work to recognize what's called a community health worker. And that was approved. And within the definition of community health worker, certified peer specialist was listed under that umbrella. But there is a real push and move in the coming year for there to be its own certified peer specialist having its own Department of Labor classification. And what that would allow is the ability to count and identify individuals who were working as peer specialists and to use kind of common labeling clarity so that even when recruitment is looked at, like how many people are recruiting for a certain type of practitioner, it would give like a naming convention. Now, I don't want the Department of Labor coming up with the naming convention for peer specialists. However, it's already in the CHW content as a sub portion. So we just all need to be aware that there's a lot of advocacy right now for peer support specialists to have their own classification so that there is ability to count and check and monitor what the hiring and recruitment and retention practices are for the field.
I just want to add one other, well, maybe 2 or 3 other things as I really think about it. But one of the things that it does do is it would allow that, if we could get the peer designation within the standard occupational classification designation through the Department of Labor, 1 or 2 of the things that we know that it will do is it will start tracking data that we don't currently have. So we know that largely across the country, peers are not getting adequate wages, but there's no formal way of capturing that information at a national level. And so like just having that information would be helpful. But then to what Wendy was talking about too, one of the conversations we've been having with the state recovery leads is how do we develop a career pathway for peers? And I think another way that another reason why that SOP code designation would be helpful is that we could start to define that career pathway. Like this is what it looks like. This is where peers are certified. This is where certified peers are working. This is what their titles are. This is how much they're making. These are the types of organizations that they're operating and working within. And so it would start to put together the puzzle pieces on the map on the peer workforce as a whole. And I know that the National Association of Peer Supporters, Tim Saubers, is here, and I know that they have a call to action out. So Tim, if you're still here, feel free to drop that in the chat. And I know that NAMI National has been working on some work. They've been working on responding to that SOC code designation as well. And then I think there's another question that just came in about it too, Wendy. Oh, no, that's for the Georgia Mental Health Consumer Network.
And I see one question about the something support academic.
Yeah, it says how long has the peer support academic been around? So I'm guessing when did it first come about, like the training?
Well, that can mean so much. So whoever it is, if you want to chat in some more, thank you, Tim.
Let's see. Another question says, how can we ensure pop-up peer certifications are vetted and not just a money grab?
Okay. So largely it depends on states and their law, regulation, or policy, which defines who is the certifying body. And so you have to just, like if you're a state authority, you have the role in law generally to set behavioral health policy and shape that. So if you really have that and you claim it, you can say that the state is the certifying body, right? And that's the only recognized body in practice. So in healthcare, you could say, like for all people who have SAMHSA grants, or for all people who have, different Medicaid products or use different Medicaid services, you can have it declared that you have to be a certified peer specialist. I'm using Georgia's name right now. That standard, and then the state then just recognizes who will be honored and recognized in that. Georgia has a policy, and we say there are only 3 entities that can train that will lead to certification. And we just make that very declarative. And we did that with a lot of intentionality. Some states really want tons, and so they recognize some national entities like ICNRC does, some addiction, peer support certification. If a state wants to recognize them, then they can. But what I suggest anytime that I'm in a state is that the state knows that it has a role as the authority to say that we're a certifying body, and that it's clear who will be recognized to do practice in the state, and that folks who are doing practice in the state that are outside of that certification are not doing it in accordance with state guidance and regulation. So I think it really comes down to state authorities to be clear about that and what that means for Georgia. And again, the team can hear, the Georgia team can acknowledge we had this conversation Friday where, we were coming to learn that a couple of universities had bought like a national suite of training which, you know, like includes like dental hygiene and engineering courses and become a certified peer specialist for $695. Well, we were having peers sign up for that, but that is not a recognized credential. Nobody has seen that training. Nobody recognizes that training. So we've had to work with universities who just pick this from a national, like they got a whole suite of 300 training events. And then all of a sudden, all of those were downloaded onto the university site, and people were finding them and being like, okay, I'll pay $695 and get trained. But that's not a recognized credential. It's not a recognized pathway, not a recognized training. They can't practice in Georgia. I don't, you know, I hate if anybody was taken for, you know, if there was any misrepresentation. I mean, they thought they'd be able to work in Georgia, but they can't with that. It's not recognized by us. And so you have to really be careful and mindful that the state is making some declarative determination on that. And the three organizations that they don't certify, they train with a curriculum that leads to the certification by the state. And that's Georgia Mental Health Consumer Network, who is part of the MHTTC, Georgia Parent Support Network, and the Georgia Council for Recovery in Georgia. So what's the deal with DBSA's peer support course? It's the same like as for Mental Health America or IC and RC. They're national companies that have products. But unless those products are recognized by states or major healthcare systems, then they are not necessarily a path to having a practice certification.
We have you guys already dropped some information in the chat. Is there any specific resources, literature, information you would recommend for independent study that might expand or enhance one's understanding, knowledge, or capabilities to better perform in the role of peer support or peer specialist? I think a lot of those links have already been dropped within the chat. And then the follow-up question or more explanation about the academic is what the person meant was who thought about the importance of peer specialists and when did the program start?
Well, I can take that one. Because I got all the wrinkles now to show the years there. Let's just say, I mean, peer support is a very old science, and an amazing researcher, Larry Davidson, you know, just always says that, you know, peer support happened hundreds and hundreds of years ago, but just not formally. And of course, AA and NA groups in the early 1900s began to grow a type of peer support movement. But it was really in New York in the late 90s that some small groups began emerging out of what was then NIAPSRS, which is the New York Association for Psychosocial Rehab Services or Practices. I can't remember the acronym. They're now called the Action Alliance. And they had a couple small groups, and they had a trainer come to try to help people who were going to lead those small groups just in a couple of municipalities. We just in Georgia had some just relationship with the New York leadership team and did some learning about it, and then started to read some papers that they were writing about it. But you know, not to be not to be held down. Georgia's like, go big or go home, y'all. We were like, let's do it statewide. Let's put it in Medicaid. And one of the things I was able to tell some Nashville leadership last Sunday evening, a week ago, was that really the importance of making it statewide under Medicaid is an entitlement. So when a state declared, like Georgia, we are going to put peer support in a Medicaid state plan, that meant that we had to invest in it statewide, because you couldn't have something in the Medicaid benefit that only people in Metro Atlanta could get, or only people in Savannah could get. We needed it in all communities. So putting it in a Medicaid state plan was a declarative, strategic initiative to say, we are putting a stake in the ground and we are going to do this big. We are going to do it statewide. And then and I was part of the original negotiating, well, I mean, myself and the Medicaid director were the negotiating group, NF2, with the federal Medicaid agency to get it approved. But then what we knew is once we fought for it and fought for it and fought for it and got it approved, we've got to train the workforce. And we need, like, if we're going to make this statewide, we've got to have a big workforce. We have to have a training. We have to have curriculum. So we invested over the next 2 years in building what became the curriculum that Georgia Mental Health Consumer Network administers for us now in many refined versions through Appalachian Consulting Group and my friends Larry Fricks and Ike Powell, who helped build the curriculum and began the first training. The first peers were certified in 2001 in Georgia. We had started the service. People with lived expertise were leading the service, but we had no credential yet, which made me sweat for 2 years till we got it done. But we're very excited. Again, we're celebrating the 25th anniversary of that hallmark agreement between federal CMS and Georgia this year for having developed the service. And we went on to work and help states all over the country to build what we so deeply believed in. So celebrate 25, y'all.
Thank you. And I see, I know Jean, you made a comment about if we had Jean mentioned had a link to the comments and page. We do not, but we definitely can add it onto our website. I copied it, and so we can get that put up. The individuals do have an option to get to the NAP's website to read about it and voice their opinions and comment. If that is it for all of the questions that we had. Well, no, that's not true. Sorry. A person did ask about CEUs. So after this webinar, there will be a link from MHTTC that allows you to give us feedback and evaluation on this webinar. It's been dropped in the chat right now. Thank you, guys. And once you complete the survey and all of that, you will get your certificate of attendance that you can then forward on to, if you're a CPS MH in Georgia, you can forward on to GMHCN. We will count that as continuing education unit. If you are CPS P or Y or AD, you would need to submit that to GPSN or the Georgia Council for Recovery. Okay. And with all of that said, I want to thank everybody that came and participated in this webinar. We had, I think at one point in time, I counted 116 attendees on this webinar. So I hope you guys enjoyed the information. I hope that you found it very informative. I know I did. I want to thank Wendy and Amy so much for taking time out of their busy schedule to talk to us about these national modeled standards. Just because it's very important for just peer workforce development and the direction that this profession is going. And so thank you for taking your time. Thank you for just the work that you guys are doing to support our profession. And if there's nothing else, does MHTTC, do you guys have anything else that you would need to add or information that needs to be conveyed if I forgot anything?
No, that was it. Thank you so much, Heather. Again, we do want to thank Georgia Mental Health Consumer Network, Wendy and Amy, for partnering with us and for sharing this information today. Again, if there are questions, please feel free to reach out to the Southeast MHTTC. We're happy to answer your questions. But yes, I think that concludes our presentation today. Thank you all so much for joining.
Thank you guys so much. Have a great day.